Okay, thanks, Lisa. I guess I don't have to introduce myself other than to say I'm an associate professor there and also a speech language pathologist. My areas of research focus on investigating treatment variables that will improve word finding and functional communication in aphasia. And then lately, my lab is very focused on creating a tool, a valid, reliable test that will measure improvements in conversation in chronic post-stroke aphasia. So again, tonight, we're really excited to welcome you to this stroke aphasia IPE event because in addition to focusing on stroke and aphasia from more traditional medical perspectives from each of our respective fields, we want to invite you to think about a much less well understood trait of stroke and aphasia, but one that's very critical to understanding a key aspect of the life-altering journey that stroke survivors face. So to help us in this effort, after we get through our short primer on stroke aphasia that the students will present, and then the facilitated small group discussions, we're very fortunate to be joined later tonight by Dr. Deborah Meyerson, a Stanford University professor who studied and taught about identity prior to experiencing a stroke. And she'll share her unique and scholarly perspective on experiencing a stroke, but also on the evolution of identity post-stroke, including her own personal journey into self-awareness and rediscovering a purpose after stroke. So in the meantime, I'm really delighted to introduce you to the second year graduate students in my aphasia class, the UMass Amherst Masters in Speech Language Pathology class of 2023, who've put together, as I said, a brief primer on stroke aphasia that they will be presenting to you over the next 20 minutes. So let me share my screen. Everybody see that? All right, I will go ahead and advance slides, or let's see. Let me get this through.
You can go to slideshow.
Right, thank you. You see the whole thing now?
Yeah.
Okay.
Great. So welcome everyone. As Professor Curlin said, we're second year speech language pathology graduate students at the University of Massachusetts in Amherst. And we'll be talking about aphasia, etiology, signs, and comorbidities, as well as how, as professionals, we can support conversations and set goals while considering the impacts of identity of aphasia survivors. And we'll have a breakout sessions after this presentation. Next slide. So what is aphasia? Aphasia is an acquired, meaning you aren't born with it. Neurologic, meaning it's originating in the nervous system. Disorder, resulting in the loss of multimodal receptive, meaning the ability to understand, and or expressive, meaning the ability to produce spoken and written language. And it's usually associated with a traumatic brain injury or tumor in the brain. So most cases of aphasia involve some degree of impairment in all four modalities of speech, being understanding spoken language, speaking, reading, and writing. So it's important to remember aphasia does not involve intellectual decline, memory disorder, confusion, or dementia. And so it's important to presume competence and not underestimate one's capabilities when working with this population. So, for example, in this picture, this person with aphasia wants to express, "I want an apple," and they know exactly what they want to say. They're just having difficulty saying it. So these are a few examples of what aphasia could sound like depending on the location of the lesion in the brain. So for example, a person with Wernicke's aphasia is saying lots of words that just don't make sense to the communication partner, while a person with primary progressive aphasia is not saying anything. And it's important to remember that when you've met one person with aphasia, you've only met one person with aphasia. There are different types, severity levels, and comorbidities that make aphasia different. So therapy should be individualized and based on your client's strengths and weaknesses.
So now we're going to talk about stroke etiology. So our brain has an extensive vascular system that's a network of blood supply, and it's really important for brain function. So when that blood supply is interrupted, you're at risk for different things such as strokes. I also wanted to note that a stroke is also called a cerebrovascular accident, or a CVA, which again is an interruption or reduction of blood supply to the brain. So the two types of strokes are an ischemic stroke, which is where there's a blockage and blood and oxygen aren't getting to a certain part of the brain. This is the more common type of stroke, and you can look in this little graphic is a really good visual. And a hemorrhagic stroke, which is when bleeding occurs due to a ruptured artery, and both of these end up damaging brain tissue, and it's really important to get help fast because it happens very quickly. So there are different risk factors that increase your chance of having a stroke. So lifestyle factors, which would be things like physical inactivity, heavy binge drinking or use of drugs. And then there's medical risk factors like high blood pressure, high cholesterol, a family history of stroke. And then other factors such as age. So people who are 55 and older have a higher risk. Sex, men have a higher risk. So these are just all things to keep in mind when you're working with people who have had a stroke.
So what are some signs and symptoms of aphasia? You can expect to see impairments in understanding, speaking, reading, and writing in varying levels of severity. Difficulty finding words is very common, so the patient's speech may have a lot of silences or filler words like or They may use single words, often nouns, or short phrases. They know what they want to say, so they might get frustrated. However, difficulty finding words can also present as fluent speech with little meaning. An example of what that might sound like is, "You know that Smoodle pinkered and that I want to get him round and take care of him like you want before." Difficulties with grammar can affect both expressive and receptive language. The patient's speech might sound telegraphic, such as, "Daughter, go store." A simple sentence such as, "It's time to eat breakfast," might be easier for a patient with aphasia to understand than a more complex one, such as, "Before you go for a walk, you should eat your breakfast." Next slide. It's very common that the patient's ability to write is impaired. Reading may or may not be severely affected, so it would be important to investigate that before providing them with written instructions or explanations. Okay, next slide.
Okay, so aphasia has many common comorbidities. So one of those would be single-sided hemiparesis, which refers to weakness or paralysis on one side of the body. Another that you might see is limb pain. So that would be referring to increased pain on one side of the body. That side is usually opposite to the lesion. So if the lesion in the brain or the place where the stroke or injury occurred is in the right side, for example, then the left side might be affected and vice versa. Another is acquired apraxia of speech, which is a speech sound disorder that exhibits difficulty planning motor movements of speech. And a common characteristic that you might see of this is groping. And so essentially groping is sort of attempting to move the mouth into the right position to produce a sound, but you might see it multiple times, the person trying, but not quite getting there. Another is dysarthria. So that can make speech sound less clear due to weakness in the muscles needed to produce the sounds, which we refer to as the articulators. And an example of that might be like speech sounds being slurred. And then there's dysphagia, which is difficulty swallowing, and that can result in aspiration, which means that food or liquid is getting into the lungs. And just another note on that, this could also cause social isolation too for a patient, because they may start eating alone and feeling self-conscious about that and sort of surrounding eating. Another one is acquired alexia. So that affects the person's ability to read and comprehend written language. And then another is depression. And so how may these comorbidities impact other areas of therapy? So dysphagia could impact a person's weight. So they could gain weight or lose weight. It may also impact modes and methods of feeding. For example, they may need a feeding tube and other kinds of accommodations for that. Alexia, so if the individual has difficulties reading, they might have difficulty with take-home worksheets and exercises, completing complex paperwork, which could include medical paperwork that's required. So that's definitely something to keep in mind and advocate for. Limb hemiparesis or pain. So they may have difficulty with PT exercises, a need for more rest time or more time to complete the exercises. They also may need to relearn to write with their non-dominant hand. And then apraxia of speech. So that difficulty producing clear speech can lead to frustration, not wanting to talk at all, other professionals not understanding the patient, and then again, depression. So that could impact in the sense of the patient having less motivation and less desire or drive to work on skills in therapy.
Okay, so when you're having a conversation with aphasia, there are a few things to keep in mind. You want to be able to maintain their social dignity. Don't talk down to them like they're a child. Respect them for the person they were and are. You want your communication to be person-centered, filled with empathy and empowerment. And then there are some environmental, physical, and emotional considerations. And then what people with aphasia have to say about supporting conversations. Next. Empathetic communication is a co-creative, responsive, two-way process in which both parties are attuned to understand each other and influence each other's experiences. So when you're communicating with someone with aphasia, it's likely going to take longer. You need to show patience. You need to show that you're interested and willing to wait for them to be able to try and communicate whatever it is they need to communicate. Next. So empathy, what does this look like? You want to create some ground rules. The real goal is going to be mutual communication and understanding, not perfect speech. So, you know, don't correct them on small little speech errors or anything that doesn't really impact communication. You want to show active listening, make eye contact, even when the person with aphasia is struggling to get words out, and just speak very clearly when you ask questions. Next. Like we mentioned before, aphasia doesn't necessarily impact cognitive functioning. So that means people with aphasia absolutely need to be included in the decision-making process for their own healthcare. And ways to do this is to provide multimodal communication, which just means sort of different ways. So gestures, including visuals, can be really helpful because that part of the brain often isn't impacted. Writing if or reading if they can do so, but they may not be able to. Next. So to create an environment that's supportive of someone with aphasia, you want to have a place with minimal distractions, not much background noise, make sure the lighting is good, maybe they're trying to lip read, comfortable seating. And then you also have to take into consideration that, you know, this person just had a stroke, so they probably are fatigued, they're in pain, they're in a ton of emotional distress. So these factors will all make it harder for them to try and use language. Next. And so what people with aphasia say is that you want to be treating the people you work with respect and dignity, and be aware that their emotional state right now is probably not going to be very good. So try and be positive and reassuring. You're going to treat the person as an individual and not just their symptoms, and sort of value them as a person. And then ask if there's anyone they would like to be involved in their healthcare, maybe as an advocate, a caregiver, but like make sure you get consent before you know, you start giving information to family members. So you need to listen to the people and find out what their specific needs and wishes are, not just what maybe their caregiver wants. You want to be giving information and explanations in a way the person can understand. That might mean slightly slowing down your rate of speech, or it can be having more simple grammatical phrases, so like simple sentences, not with a lot of complex parts. You're going to want to give information at every stage of the care and family if appropriate. And then you're going to want to make sure you're collaborating with the other professionals, and then make sure you are asking for consent to give treatment, any kind of treatment, to the person with aphasia. All right.
So following a stroke or traumatic brain injury, people with aphasia often face an abrupt shift in their sense of self. So overnight, your sense of occupational, relationship, and familial and social identity can abruptly change. So starting with occupational identity, it's often the case that individuals with aphasia are employed at the time of their stroke or traumatic brain injury. So with an abrupt onset of moderate or severe aphasia, it's often not possible for people to continue working in the same way they were before a stroke. So it's important to encourage people with aphasia to find alternate ways to contribute. So some examples of that can be volunteering, getting involved in new hobbies with others, or becoming active members of an aphasia support group. In terms of relationships and family roles, before a stroke or TBI, people with aphasia often held specific roles in their relationships or their families. So some examples of this are maybe driving your kids to school, being a coach, managing the finances in your family. But after stroke, people with aphasia often find themselves having to navigate a new dynamic and discovering a new role within their relationship or their family. So it's important to encourage people with aphasia to embrace this transformation into the new and find alternate ways that they can contribute. And then in terms of social identity, many individuals with aphasia go from being extremely outgoing, social, and talkative to withdrawing from social events and avoiding situations where they have to introduce themselves or converse with others due to challenges with communication. Next. So the different challenges that individuals face when rediscovering the self-identity. We know that any type of language loss, including aphasia, dramatically affects identity because we use language to tell other people who we are. And when this communication gets interrupted, it can be really difficult to understand how your identity is constantly changing. So some examples of these, what are called identity dilemmas for people with aphasia, are consistency and change. So you might feel some aspects are the same as you were before the stroke, but then other aspects of your personality may be different. You can also be same and different in your relationships with others. And you might experience both being still capable of doing things that you could before your stroke, but then there might be other things that you are now incapable of and might need some help with. So this quote on the right basically says that research has shown that encouraging people with aphasia to tell their stories is a really important rehabilitation tool, and encourages people to accept their post-stroke identity and continue to tell the story of their new self. Next. So just a super quick introduction, because we will be hearing from Dr. Deborah Meyerson and her husband, Steve Zuckerman after our breakout room discussions, but our SLP cohort started off our semester by reading this book, Identity Theft. And we learned so much from Deborah about different ways that identity can change after an aphasia diagnosis. And if you're interested in learning more about this topic, I cannot recommend this book enough. Next.
There's also psychosocial impacts of aphasia on both individuals and families. Due to their communication disability, people with aphasia report difficulty accessing mental health services, treatment programs, and support groups that can meet their psychological needs. The psychosocial impacts of individuals include poor occupational outcomes. It can lead to relationships, changes in their relationships, social isolation, and there's a higher incidence of depression than that of the general population. The psychosocial impacts on family members include increased likelihood of developing depression and increased stress related to communication, relationships, responsibilities, hobbies, and interests, as well as finances. Next.
All right, so to finish up, we wanted to touch a little bit on setting goals in healthcare. So when doing this and having these sometimes already difficult conversations, you really want to remember to work with the whole entire person. So kind of taking a step back and really thinking about this person's daily life, their strengths, their weaknesses. Think about how they are best communicating in the moment. So is it with gestures? Is it with visuals? There are a few main things to kind of keep in mind when navigating these conversations, making sure to keep it client-centered. Remember, they're making decisions that impact their own lives. Even if they do have a care partner there, be sure to direct the conversation towards everybody. So if this is a non-fluent aphasia, it might seem like they're not participating, but they directly need to be involved in making these decisions. Thinking about the primary concern for one professional might not necessarily be the concern for another. So the SLP's focus is with the aphasia, the PT's might be with hemiplegia. So kind of challenging yourself to think about the overarching goals and how your goal setting might impact the other and vice versa. And then finally, when discussing your goals, repeat, rephrase, use gestures, try to keep language as concise and clear as you can. Falling back and thinking about how that person best communicates in that moment and kind of using that to guide everything that you're saying. Something else to keep in mind is when asking yes or no questions, it can be tricky to tell if the client is actually meaning yes or no. Oftentimes they might nod yes and then say no. So rephrasing things to make sure that you're both getting the point across and really making sure that you're being understood. So overall, I think just as long as you're working directly to involve the patient in their goal setting, involving the care partners, and really thinking about that big picture, then you're on track to having a productive and impactful conversation. And that is what we have for you guys. We're happy to take any questions now, but we are going to be going into our breakout rooms to have more informal discussions. So
Thank you for that, SLP students. And if we can hold the questions either for the breakout rooms or later, because we're just exactly running on time right now. All right, good. It's my great pleasure to introduce our guests of honor this evening, Dr. Deborah Meyerson and her husband, Steve Zuckerman. Dr. Meyerson taught and studied about diversity, gender, identity, and organizational change at Stanford University. Her career and life path were derailed 10 years ago by a stroke that initially left her hemiplegic and unable to speak. But that experience turned out to be the beginning of a life-altering journey into self-awareness for Dr. Meyerson, for her family, and now thankfully for thousands of other stroke survivors and their care partners who've come to know her work on identity and life purpose after stroke. So her powerful book, which Kate mentioned earlier tonight, Identity Theft, examines the rebuilding of a life post-stroke. It's co-authored with her son, Danny Zuckerman, and with help from other family members, including her husband, Steve. I just want to say, if you haven't already read this book, I seriously urge you to pick up a copy after the event. It will be the one book that you will want to recommend over and over to stroke survivors and their families on your caseloads as they begin their own journeys of self-rediscovery. And in doing so, you'll also be contributing to the nonprofit Stroke Onward that the Meyerson-Zuckerman family has generously founded to help others navigate their emotional journeys to rebuilding their identities and rewarding lives post-stroke. So the last thing I want to add is that last year at the end of our Stroke Aphasia IPE event, we learned from Deb and Steve about their plans for this crazy Stroke Across America cycling event, a journey from Oregon to Massachusetts to raise awareness for stroke and aphasia. So I hope they'll be sharing some of their incredible journey from this summer with you today.
Yeah.
And I can't wait to hear what might be in store next year.
Yeah. I don't know.
Please join me with a warm welcome for Dr. Deborah Meyerson and Steve Zuckerman.
Thank you.
Yeah, thank you.
We just move to the next one since you've already introduced us. We can skip our introductory slide.
And the audiobook is out.
All right, take it away, Deb.
In 2009, I became lectures at Stanford easily, confident, strong, and casual. I encourage students to explore topics like gender, diversity, race, and identity. In 2010, I had a severe stroke. It rid me of all speech. I had to relearn how to make a sound, how to say my name. How am I now? I'm alive for this. I'm grateful and lucky. Many things have changed. I live with disabilities. My right hand didn't work. I walk with a limp. My speech is really difficult. But some things haven't changed. I cherish the same values, love the same family, work with the same determination. Losing my old life was the hardest part of my stroke. Rebuilding my identity as a stroke survivor with disabilities is the hardest part of my recovery. My stroke took so much of from me: independence, control, my career, and so much more. But for me, I was the same person. So I had to get my capabilities back. For 3 years, I worked my ass off, the hardest job I ever had. With all this work, I still didn't regain all my capabilities. I couldn't be the Stanford research professor anymore. The aphasia didn't let me do the job. So 3 years after my stroke, I lost tenure. This was a huge blow. What do I do now? Who am I now? My identity crisis, my identity paresis began?
So we talk a lot about stroke being a family illness, and while Deb was kind of going through that early journey, I was going through my own, and I'm not going to talk in depth about this slide, and certainly if I were a better graphic artist, I wouldn't have made it look so linear, because clearly it wasn't a progression through these experiences, but they all sort of swirled together. But, you know, fear, particularly at the beginning when Deb had been diagnosed with a stroke and they said there was nothing they could do, but we wouldn't know for at least 24 hours how bad the damage was. When Deb had to have surgery to repair a tear in the wall of her artery. I mean, a lot of just fear of the unknown, fear of, the experience, fear of losing Deb. I'm sort of a natural problem solver, and kind of once, it was clear that there were things that needed to happen to support Deb, that was kind of I went into that mode. It was sort of, okay, what do we need to do? How do we get this done? And I put up care partner versus caregiver, because from the very beginning, and I think I've talked with a lot of people who have family members who have had strokes, and that's a bit of a struggle, because at the beginning, at least, you really are in this position of having to give care. But you may not be surprised that Deb made it very clear, even before she could literally get a sound out, that she wanted to be a partner in her own care. She didn't want me or her mom or anybody else to push her out of the way and be solely responsible for her care. That phrase care partner took on a different meaning later on, as we started to rebuild our lives and our relationship, and realized that the phrase caregiver makes it very hard to rebuild a true partnership. And in life and in marriage, we had always wanted to be partners. So that's kind of a big point for us. I was really lucky that I had very close friends, some of whom had people go through things like this before, who warned me, take care of yourself. If you burn out, if you can't deal, then you're no help to Deb. So both for yourself and for her. One of those wise people is Jody Kravitz, who's been a friend since college, who really made sure I thought about that from the very beginning. I put up single parenting because, again, Deb and I had really partner raised our 3 kids. And when Deb had her stroke, 2 were out of the house in college, 1 was still in high school. But all of a sudden, I had to renegotiate how to deal with all these things that we used to share. And certain, for Deb and me, sharing was often dividing and conquering. So the pieces that she had taken and conquered, I now had to figure out and find out what needed to be done. There is no way my frustration could ever be compared to Deb's, who's going through it and who's lost capability. But it's very real and it's very significant. And I think as you work with people who are the supporters of stroke survivors, realizing and supporting them through frustration is important. Sometimes, I blow up in frustration and say, what is it? You're allowed to be frustrated, but I'm not. The reality is lives change for everyone, and that's frustrating. And purpose is something that we talk a lot about in a lot of contexts, but for me in this early time, I realized that I had to reorganize a lot of what I did, not to give up everything, because that would not be very good in the self-care department, but that I really had to organize to be supportive of Deb. And there was a little bit into, we didn't see this right away. This is, you can tell I have never had and should not try to have a career in art. This is a hand-drawn replica of something that Susan Silk, a clinical psychologist, wrote about which is the ring theory of support, and that Deb, the person who had the trauma, is in the middle. I, as her closest supporter, is in the second ring. Her mom and our kids, who are kind of the next closest in terms of the impact of the trauma and the ability to support Deb, are in the next ring. And that kind of in that traumatic situation, you should always be thinking about how do you provide support looking in the ring, and how do you ask for and get support from people outside you in the ring. And I think that before I saw this, instinctively knew that my job was largely to look inside and support Deb. What this really helped me realize is I had to ask for help from the people outside me in the ring. And even more importantly, that I couldn't make it my job to support them. And as a natural caregiver, I often wanted to. How do I help her mom get through this? The kids get through it. And this was really helpful to sort of organize my priorities during that period of time. So that was some of what I was going through during this first 3 years. And now Deb's going to pick the story back up kind of at that 3-year mark. If I can advance the slide.
That after I lost my job, I really struggled. I didn't know what to do. I had felt lost. I still felt like an academic. I wanted to be an academic, but I called I can't be. The bad news, I was restoring my old identity. This led me to think about the past work, and it's painful. The good news, that makes me think about the book I wrote in 2001, Tempered Radicals. The identity was a big part of this story. I thought about another book. It turns out writing the writing identity is so key to figure out my own identity. The first academic thing I did after the 4 years after my stroke was return to the gathering of trusted colleagues. I was struggling with my identity. I wanted to write a book about identity and stroke, but had I write the book, I knew it's a lot of work. I had did it before, that I did but that I do it again with aphasia. I don't think so. I shared my ideas with my colleagues. They pushed my thinking. That the meeting was a deep dive into what's important and essential, what we care about most. They helped me focus on that. They helped me search turning the meaning now. Showing me how to important support is. Now, the learning identity theft became my learning journey. It took me 5 years, and I learned and to accept really a lot of help. I didn't want to remember. I learned to most survivors will not hold that identity was so important to recover. It's so important. This the book is not that's my story. With help, I interviewed more than 55 people. There's ages, backgrounds, stroke types, and experiences of life and stroke.
So Deb said she was apprehensive about, could she write a book with aphasia? And, you know, Deb is Deb, and she said she's as determined as ever, and she sat down and started writing a book. But she did realize pretty quickly that this thing called aphasia was a pretty powerful obstacle, and she would need some help. She looked for the nearest and cheapest source of help she could find, and that was yours truly. And for about a year, maybe almost 18 months, we worked on things, we outlined stuff, we really tried to get at what it was she wanted to say. But the reality was, at the time, I still had a full-time job, and I'm not a professional writer or editor. And we realized that she was going to need some more help. We were fortunate to find a woman named Sally Collings, who's an editor, an author, a ghostwriter, happened to live in the town next to ours. And we were able to bring her onto the project. And she really became, you know, Deb's researching and writing partner as we kind of determined what kind of interviewing needed to be done, what messages Deb wanted to get to. Sally helped design the interviews, do the interviews, transcribe the interviews. And we would get together as a group and really try to say, okay, where is this going? And we created outlines for chapters. And Sally worked most closely with Deb to really turn that into a draft. And we were super excited when we were, you know, she was like, she had drafted stuff, we had given her feedback, she was ready to deliver us the sort of first full draft. And Deb, Danny, and I were all actually headed out of town into the mountains to work remotely. And we were like, great, we get to read this, tweak it a little bit, and send it off to the publisher. And we all kind of went into our own rooms and read it. And we came back, and you could just tell the look on everybody's eyes was it didn't hit the mark. You know, we wanted to love it. And there was a lot of good stuff in there, but it didn't have Deb's message. It didn't have Deb's voice, and we all knew it. And fortunately, Danny, our oldest son, was in between jobs at the time, and he saw the panic on my face and basically said, you know, how about I kind of step in because I've got some time and really work with you, Mom, and try to turn it into the book you want it to be. And he really kind of took the lead helper role to drive the book over the finish line, and that's why he's the named co-author. But I think that story of how to write a book with aphasia, it's so critical because it's so reflective of how different life is. Deb had written books before, and it was a very different process. It didn't mean that with aphasia she couldn't write a book. She just had to do it differently. And that's kind of a metaphor for a lot of what we talk about. Deb talked about the importance of diversity. And if we have more time, I might go through these 3 stroke survivors, all of whom were interviewed for the book, and they're in the book. But, you know, suffice it to say, they're all very different. They're very different people. Different ages when they had strokes, different life backgrounds. And that was true. We love a phrase that somebody used in a meeting we were at where a neurologist said, you know, it's incredible when you've met one stroke survivor, you've met one stroke survivor. And that really is the way it is in the world of stroke. But with all of that difference, and it was really important for us to bring that difference out, there were also some incredible similarities. And 2 of the most notable were, one, this group that we interviewed worked incredibly hard for years. And when Deb had her stroke almost 13 years ago now, a little over 12 years ago now, she... You know, there was still a lot more of a trope in the industry that it was like, well, most of the recovery happens in the first 6 to 12 months. Fortunately, that's starting to break down, but there are still pockets in the medical community that still say it all the time. And it is just not, I mean, most happens in that amount of time, but everybody that we interviewed was still improving years if they kept working hard. The second thing, which really drove our work and where we are today, was that nobody, like Deb, was given any real guidance to say, okay, you may not get all your capabilities back, but now you've got a second part in recovery. You've got this emotional journey to rebuild your life. And that just was not present in the medical community at the time, and we would argue still isn't. I think that in writing the book, Deb very quickly, being a social scientist, and I can only see 25 people at once, but how many of you have heard of Maslow's hierarchy? Psych 101, nods, raise your hand. You know, this wasn't written for people with disabilities or for stroke survivors. You know, he created this as his belief of what motivates people. All people. And some people debate it, but it's pretty widely held. And what Deb realized is that she had been living her life, you know, kind of up in the upper parts of that pyramid, self-actualization, self-fulfillment. And she got knocked on her, you know what, all the way down to the bottom of the pyramid. But that once she was safe, once she got through the medical crisis, once she started to be able to feed herself and live more independently, that there was no reason she couldn't climb back up the pyramid. And that's really central to her experience and to what we're trying to help more people realize. Go faster? Yeah. Okay. My metronome is telling me I got to speed up the pace. I mentioned stroke as a family illness. That's chapter 9 of the book. I like to say, if you're in the mood for a good cry, just open it straight to chapter 9. It starts with our daughter's story of her experience in you know, with Deb's stroke, and it just not only does it show how much impact it had on her, but it showed how much it changed who she was as a person. And one of the things we really stress is that this identity journey is not just a journey for the stroke survivor, it's a journey for the family as well. We change as people. We just don't have our lives change. And then the last thing I'm going to say, so Deb doesn't smack me, is that, you know, when we first started talking about this work, it struck me that Deb's writing journey changed. It started, as she said, to prove she could. She was hanging on to her identity as an academic. She was told she had to leave her job at Stanford, but damn it, I'm going to prove to people I'm still an academic. I'm going to write a book because that's what academics do. But very quickly, it became her learning journey and pointed out how critical that emotional journey to rediscover identity would be to her recovery. Even with that, there were a few times during the writing process when she came downstairs and said, I'm done. I don't care. This is too frustrating. And I often say that it's unbelievably brave when aphasia is your biggest disability to decide to write a book. You're putting yourself face to face with the most frustrating thing every day. And what really got Deb to push through that frustration, whoops, I guess I was a click behind, was to help others. That she realized there was a void out there and people needed this message. And we talk a lot about purpose and that being what drives us to do things we might not otherwise do. And that this whole writing journey really reflected her personal journey. We talked and Deb talked about the importance of identity. So I'm going to pass it back to Deb to. You want to skip these two?
Yeah.
Damn, I think they're the two best slides, but you know, he's the boss.
We all have multiple identities. I had to remember I am more than the job at Stanford. I'm a mother, wife, daughter, friend, teacher. I love skiing, biking, walking, sailing. I had to think about all the things that makes me me. Identities change. We are changing all the time. Right before the stroke, I was not the same person I was for 5 years before, or 10 years before, or 11 years before. My stroke changed me faster, but I was changing anyway. Identity is the social construct. We are who we are in the context of relationships. My relationships, my friends, family, and the colleagues are a big part of me, who I am. What's important, identity is the choice. Accept it, instead of asking who am I now, ask how do I want to be now. My sense of self, that my identity is was strongly affected by your situation, your race, gender, social status, and more.
So, it turns out that getting the book published, which we at first thought would sort of be a finish line, was just a starting line. That there really was this gap in the medical system, that the message of the book, we thought was just dipped a toe in the water of trying to make an impact. And so, as Jackie said, we started Stroke Onward as a nonprofit to really continue that work. Super quick, our mission is to ensure that survivors and their supporters have the resources to rebuild identities and rewarding lives. It's that second journey in recovery that we often talk about. Our vision is that someday the stroke system of care just does that people who have a stroke or whose family have a stroke 10, 15, 20 years from now enter a system that is more whole person oriented and provides this kind of support. In terms of our actual work, we do a lot of, if there's a gap, we got to let the people who can make a difference know it is. And so that's the sort of the raising awareness piece. We then, I was a click behind. We get people who say, yep, we agree, that's great. So what do we give people? There just isn't a lot out there, counseling, materials that is focused on this. So that's another piece of our work is how do we create more? And ultimately, all of that work really is in the goal of changing the system, so that it's not just serving a few people, but it changes the system. And on largely the raising awareness piece, Jackie said we had this little adventure this summer. And Deb's gonna talk about it a little bit.
Oh, what?
That's you.
The Stroke Across America was a bike ride across U.S. and Canada to raise the awareness about stroke, brain injury, and aphasia. We wanted to spotlight the emotional journey after stroke. How do we build our identities and live meaningful lives? We rode 4,500 miles over 100 days to the Oregon to Boston. We had a team of 6 riders and others who joined us of the portions of the ride. We became a family. I didn't expect that.
So just to expand on that a little bit, while our organizational mission really is around that central panel of recovery is rehabilitation and rebuilding, we intentionally made the trip broader than that. We wanted to build awareness for stroke and the BFAST kind of signs of stroke, and also about aphasia, just because it is so poorly understood in the United States, that we wanted to make the trip relevant and accessible to as many people as possible. In addition to the riding, we held 16 community events across the country. And that really turned out to be one of the highlights of the trip. Bringing communities of stroke survivors together, that sense of community, the sense of learning, was just, I mean, it was inspiring for us, and we think went a long way to achieve the mission of the ride. Sometimes we get asked which was the best community event of all of them. And of course, it was the one in Northampton, without a doubt. And we seriously, Jackie, cannot thank you enough. It was, honestly, it was one of the events that came together later than a lot of others, partly because it was later in the trip. And the organizing you did and the people you brought to the event, we just left so excited and can't thank you enough. We, if our technology works, are going to share a little video that is up on our website. All right, share. You guys see that?
Tell me of the man of Steve and Deborah, the cyclists. You are loved. Cycling across America, 4,300 miles.
This initiative, this project takes advocacy and awareness to a national level of awareness.
So we're 50 miles into a 76-mile day.
How do you go from a professor who teaches about creating change and using your voice and an athlete to somebody who's disabled, fully on your right side and can't speak? And how do you reconcile that with how you saw yourself beforehand?
I am Deb Meyerson. 2010, I had a severe stroke.
We're climbing. We're climbing.
Stroke Onward is about raising awareness around the importance of the emotional journey of rebuilding identity, and that is a critical part of the recovery process. But we decided very early on that we wanted to have a broader purpose to the trip to make it more relevant to more people, more easily accessible to more people. And so we really structured it around raising awareness for stroke, for aphasia, which is very poorly understood in the United States, and the importance of the emotional journey and rebuilding identity.
My name is Maggie Whittam, and I had a stroke 7.5 years ago.
Doctors told me wheelchair for life and no talking. I believed them. 4 long years.
It is a loss of the ability to communicate. It is not a loss of intellect. And that is so important for people to understand. And unfortunately, that's not how people are treated.
I don't want this trip to end.
2 rules. 1, never quit. 2, never quit.
I'd like to think about what's next. My journey is full of challenges. I'm building a new life. I have new limits. But I am
an active mother, partner, and athlete. I am still rebuilding my identity and rebuilding my life. So who am I now? I'm a stroke survivor. I had frustrated more than it used to be, but I'm lucky to be alive. I have great support, and I have purpose in the meeting again. To be clear, we not figured that out. We are still on the journey, and we are going to be for life. Thank you.
All right. Now we're done.
Yeah.
Wow. Wow, you guys. So I don't think we're going to have a lot of time left for questions this year, but I want everybody to please join me in thanking Deborah and Steve for their incredible generosity and sharing these experiences with us tonight, but especially for opening up this really critically important conversation about the complex nature of rebuilding identity after stroke. So thank you so much, Deborah and Steve. Maybe you have time for one or two questions.
We do have one other team member who was offended that we didn't explicitly introduce her. So we'll bring her into the Q&A. This is Rusty. Oh, this doesn't look like a bashful crew. Somebody's got to have a question.
Well, I know Deb and Steve from the last time that I attended one of your talks that you spoke really compellingly about some things around, like counseling and mental health services for people with aphasia. And we have a number of students here this year that are from social work programs.
Oh.
And so I thought that this would be a great opportunity for you to talk a little bit about that, because I know you often talk to OT, PT, and speech, but maybe not so often social work students.
No. Yeah.
Yeah, I mean, that is one of the places where we're very focused. And our sort of growing hypothesis is that stroke really grew up in the medical system as an acute care condition. And so it gets treated as an acute care problem, but it didn't grow up as a chronic care condition. And, the other conditions that are chronic from the beginning tend to have a lot more mental health support built into the care system, whether that be counseling, social workers, psychologists, psychiatrists. And so we kind of think that's just, we're not sure exactly why people never said, wait a minute, you've got all these people who have a life to live that's very different and has disabilities. Why aren't we helping them? Why aren't we giving them those kinds of mental health resources? And so that is one of the things we're very focused on, to figure out why is it not happening and what might be done to help make it happen more.
And Jody is.
No, haven't figured it out yet, Deb. We're working on it.
Yeah, what's the answer, Jody?
Just getting off the call. Sorry, no.
Yeah, no, I mean, I think what's been striking is how few people in the mental health professions, and there are many of them, think of stroke as an area for them to work. And so we are, and Jody is taking the lead on talking to the handful of people we've met who are doing that, but lots more who aren't, to kind of try to better understand that dynamic and what the barriers are, so that we can then see what we can do to maybe break some of those barriers down.
And if I will welcome anyone, if you on the call, if you've got thoughts about that or thoughts about people we should be speaking with, please be in touch with us. And Deb and Steve will share an email at the end of the call, and I'll put it in the chat as well.
I just wanted to say that there's a lot of nursing students here tonight too, and if there's anything that you have to say to them specifically, experiences you had with nursing during this whole process, and any words of wisdom for them as nursing students?
I don't know.
So I will just tell one story. So we were lucky that we had, by and large, phenomenal experiences with the nursing professionals that we encountered. I will say that a nurse was the one person that it was actually when Deb was still in the ICU, and there was a nurse who, and please forgive me if I'm stepping on any toes, who kind of used that baby talk voice when talking to Deb when she had no speech, and then would talk about anything substantive. She would look at me as if Deb wasn't in the room and refer to Deb in the third person. And she walked out of the room, and Deb at that point could not make a sound, and Deb just shook her fist as if she would have punched this woman. And it's the only time in our entire journey that I went to the charge nurse and said, please don't have that person come back into our room. It's not good for Deb's recovery. So, and as I said, that was the anomaly that most people, and I will actually say nurses were by and large more sensitive to the fact that a person with aphasia still had their intellect and still talked to Deb in a way that was more respectful than many of the other health professionals in the inpatient hospital setting.
And
so that's what we would encourage, is to really be sensitive to that.
And
Great, thank you.
the NDs are especially bad.
So should we make it the nurses' jobs to train the MDs to make sure they get
They
it better?
try. They really try.
So I guess we've gone over time here. Again, I really want to thank Deborah and Steve, and there are tons of thank yous in the chat. I don't know if you've had a chance to see,
Yeah.
but we'll make sure to send them to you. And there's also a request from Jody at strokeonward.org, who'd love to hear thoughts on mental health needs and barriers from anybody who's thinking about that after this event. I want to thank everybody for showing up and participating. Don't forget your post-event surveys. And Deborah and Steve, I didn't hear about the next big thing.
Yeah,
but
the next big thing is, I don't know.
As Deb said on the video, we want to think about what's next.
Yeah.
It's I don't know, mental health across America, something like that.
I love it. Count us in.
Well, just to repeat, Steve and Deb's thanks, Jackie, the work that you did. Lisa, I never knew you could sing. You guys were wonderful.
Oh, yeah.
That was awesome.
Yeah.
Really, really fantastic. Can't thank you enough.
Now, if everybody here, if you guys haven't heard it, I think you need to, demand a singing performance, at some point during your experience.
So much talent.
It's getting you into trouble, Lisa.
That's all right. We actually have a choir for people that have, challenges with their communication. Because music is amazing for people, particularly people with aphasia. Music can really allow them to express themselves.
And the long time ago, I had the music therapy in Boston for 4 months of music therapy, and 1 hour, 1 hour and a half every day.
Melodic intonation therapy.
Amazing.
That was in our phase when we were trying to find any and every clinical trial that might be helpful, and something to raise for stroke survivors. You know, can be a great way to be able to get more therapy than insurance covers or private pay is reasonable. So that was great. All righty. Well, thank you all.
Thank you so much. We really appreciate your generosity.